All right, thanks. I see you all sit similarly to what my residents do in rounds, the residents on one side and the attendings on the other. We just don't have the gap in the middle that you all have. I guess you have to mind the gap here, as they say. Anyway, what I thought I would talk about is something that occurred during my lifetime, which is basically the advent of PSA testing and the number of papers that shaped our thoughts. And basically, it's my own research journey as I came from residency in 1980s where PSA did not exist. For the residents, I had a chance to chat with them yesterday, and we were talking about a little bit how back in the 1980s, many urologists were the recipients of patients who presented with widespread bony metastases, usually came in with bone pain, weight loss, and they came to us because we were the ones to do the bilateral orchiectomy and coax them along another couple of years before they died from prostate cancer 3 or 4 years later. It's that background and that paradigm that PSA testing took off from. And if you don't share that history, you might not understand why we do the things we do today. So let me talk a little bit on some of the papers that shaped what we did. For those of you, PSA was actually discovered, some would argue, in Roswell Park, New York. Others say Tom Stamey had an impact. But the bottom line, PSA has been around through the 1970s. It was originally discovered in the semen. In fact, some of the scientists in forensic medicine thought that it would be an interesting tool to follow up on rape victims. But it was not until this publication in the New England Journal of Medicine in 1987 from Tom Stamey's lab that PSA was put on the map for prostate cancer. It was touted as a marker for this disease, and I'm looking for the pointer. Here we go. It was touted as a, sorry, did I not have the right one here? Oh, you said go this way, right. No, you told me that. There we go. It was a marker for prostate-specific antigen. It was not actually set up as a screening tool. And if you look at one of the key figures from this publication, this was the correlation that Tom Stamey showed us. Remember, his pathologist was John McNeil. For those, again, for the urology residents, that wonderful picture of the different lobes of the prostate, that's all John McNeil's work. He used to publish that 20 years ago, and the rest of us who went into urology didn't understand any of that until we bought an ultrasound machine and discovered he was actually a lot smarter than we thought he was when he published them initially. But the reason why I'm pointing this out is the x-axis focuses on PSA values that many of you don't associate with screening. In fact, these are classic values for metastatic disease. And what John McNeil did was he would take Tom Stamey's radical prostatectomies and he would basically cut them up, step section them, and actually would quantify the amount of tumor. So on the y-axis you have tumor volume on a log scale, x-axis PSA, and what Tom Stamey said that this was a wonderful number that correlated with tumor volume, and this is the correlation matrix. It wasn't until 1991 when Bill Catalona was the one who first recommended that we should use this test for screening purposes. And as you said, this is a measure of screening for prostate cancer published in the New England Journal of Medicine. And he went on not only to recommend testing on a single basis, a subsequent manuscript that came out a few years later in 1996 referred to this as repeated PSA testing, in other words, longitudinal screening. But it was this manuscript in 1991 that set the bar at 4 nanograms. Prior to 1991, shortly after I had moved to Connecticut in 1987, we were still struggling on what the correct number was to consider doing a biopsy. In fact, I still remember the late 1980s, there were debates whether you should consider doing a trust biopsy for someone with a PSA of 8, 9, or 10. We didn't quite understand what the numbers correlated with, and it was this paper in 1991 that overnight set the bar as 4 as the cut point between doing a biopsy and not doing a biopsy. As I said, he followed that up. Deb Smith, who was a graduate student with him at the time, she subsequently went on to Yale University Med School, but they published this in 1996, the idea of using PSA as an annual screening test. And he further followed this up in 1997. As you know, Bill kept trying to push that cut point lower and lower. This is when he began proposing using serum PSA concentrations between 2.6 and 4.0 as a method of detecting prostate cancer. And he came up also with an alternative metric, something called free PSA. I don't know how many of you still use free PSA as an alternative metric to try to improve the performance of PSA as a screening test. But this was the key slide that Bill Catalona used to set the cut point at 28%. His comment was if you had a percent free PSA below 28%, there was a much higher probability of prostate cancer. But if you look at this graph very carefully, you can see the triangles are cancer, but the open circles are all the men who underwent a biopsy who had no evidence of cancer. And when you look at that graph, I hardly think the population of men with cancer versus those without cancer are crisply separated here. So I don't know how many of you use this test, but this was the original publication that focused on how it separated these two populations. The one thing we can all agree that PSA testing has done is dramatically increased the number of men, and I'm sure the same graph is true for Canada. I just haven't seen a Canadian graph, but this is the SEER system, the Surveillance, Epidemiology, and End Results Program of the U.S. That's how we track cancer cases. And you can see Tom Stamey's publication, 1987. Here we go. And if you draw it up, it's right about there that we started the PSA testing. Catalona was 91. And as a consequence, shortly after I got to Connecticut as a young attending, overnight we saw this huge avalanche of patients with newly diagnosed disease. At the time, some of them had more advanced disease because a number of these men had PSAs of 20, 30, and 40. And when we went to do radical prostatectomies on a lot of these patients, we absolutely did a pelvic node dissection first. Now, as I was telling the residents yesterday, as many as 20 or 25% of these men would actually be found to have positive nodes. And the teaching back then was if you had positive disease, grossly positive nodes, you would not do the radical prostatectomy because you realized you would not impact their longevity, and yet you would expose them to the potential morbidity of either incontinence or impotence. We culled out a lot of prostate cancers after 1993. In fact, the projections back around 1993 called for over 300,000 new cases of prostate cancer, and the projections on the number of men who were going to die from this disease just went off the chart. Until about 1995 or 1996, there was a retraction published in CA, a cancer journal for clinicians, when we began realizing that the data, because this data is lagged by about 3 years. These are all projections when they get published in the Cancer Journal Clinician, but the actual number count takes about 3-year lag between what's projected and what is actually found. So the drop in this incident number was only found out in about 1997. And that's when we realized that PSA testing has now stabilized at a new level. That's about twice the rate we were diagnosing this disease in the 1970s. I point this out in contradistinction to the UK. In the UK, they do not do PSA testing. They're just starting to see PSA testing in the UK. But they don't, and through 1997, you can see they don't see this sharp bubble. So I think everybody is convinced that in epidemiologic circles that the rise in incidence is directly a function of PSA testing in North America. So this leaves us to a quandary. As you know, prostate cancer screening is strongly supported in the US and Canada, but is actively discouraged in most European countries. I know the Norwegians do not support it at all. The UK will tolerate it. In other words, if someone in an internal medicine trust requests it, I think they cannot be denied that test any longer. But as public policy, the Danes don't particularly screen for this disease. The Swedes don't. The Dutch are a little bit not sure which way to go. As you know, Fritz Schroeder's ERSPC trial is probably going to be published in another year or two. But that's been going for over 8 years, and if they had a dramatic difference in screening, they would have published already. And when you listen to Fritz, you can sense the way he's changing his tune over the last 4 or 5 years, where he originally thought that this study would be grossly positive. It's now becoming apparent it's probably going to be a negative study. So the dilemma is, does prostate cancer screening result in decreased mortality? Because ultimately, from an epidemiologic point of view, the reason why we're doing this is we wish to lower the rate of prostate cancer death. And the question is there a direct link, cause and effect relationship between screening and treatment and decline in mortality? And why could there even be a question about it? Because we know that annual PSA testing can identify many men with localized disease. There's no question in anyone's mind. The big question is, how many of these men are destined that you found, how many of them are destined to die from the disease? And among those men who have clinically significant disease, how many of their courses are altered by the interventions we dream up, whether it's surgery, radiation, HIFU, cryosurgery, and all the different things we've dreamed up to beat up a prostate? Do they really alter the outcomes? And what's the evidence we have for that? Well, it was that background that I struggled with this problem and began saying, because when I was in Connecticut, I began seeing a lot of men in their early 80s basically being diagnosed with disease, going for bilateral lymph node dissection, some of them having some pretty nasty complications. We actually killed a few patients, not I, but some of the folks in the community. And I asked the question, what were we trying to accomplish by doing node dissections and surgery? And it led me to ask the question, what was the natural history of this disease? And this is where I bumped into a very serendipitous finding. The state of Connecticut has the oldest active tumor registry in the United States. I didn't know that when I moved there, but it's one of those things I discovered. And I was able to access a lot of men who were diagnosed in the late 1970s and 80s and spent about 2 years trying to track down who these men were, track down their slides, and basically close the loop by going back to the State Vital Statistics Bureau to discover what they died from and when they died. And we put together these graphs, which I have to credit Jim Henley. Jim Henley is my statistician. He works in McGill. He and I have had a wonderful working relationship over the last 20 years. He's a great statistician. I've been to Montreal to see him, I think, twice in my life. We spend all the time just working over the internet, but it's been a very fruitful and collaboration. But what we attempted to show in this was the struggle that I face when I talk to my patients was this relationship between age and Gleason score. This trade-off between quality and quantity of life and who actually was threatened by this disease. When we did our initial analysis, it was still relatively rare to see men in the 55 to 59. The numbers there were actually fairly small because back in the 70s, we didn't diagnose this disease in that younger age group. Nowadays, I see men in their late 40s and early 50s fairly regularly. Again, this is all a function of PSA testing. We have moved the date of testing, or we have moved the date of diagnosis up by at least 5, and some people would estimate as much as 10 years compared to the pre-PSA era. So these graphs are all based on men in the pre-PSA era, identified either because of a nodule or because of transurethral resection. About a third of them are TURs, about 2/3 are palpable disease that none of you even see any longer. But the big message that came out of this analysis was the men with high-grade disease, Gleason 7, 8, 9, and 10, had a very lethal outcome if left alone. The black area represents those men who went on to die of their disease. These are 20-year outcomes. The gray, which you see on the lower part here, are men who died of other causes. So in other words, right here it was either heart disease or something else. But even among men in their mid-70s, you have a 40 to 50% death rate from prostate cancer if you did not treat or alter this. It didn't say the treatment would cure these folks, but the point is the natural history of the disease is high-grade cancer kills. In contradistinction to the low-grade cancer, and yes, we don't see, the natives are restless out there somewhere, we don't see many 2 through 4s and Gleason 5s any longer, but we'll talk about that at a little later on in the talk. I lost that comment? Oh, thank you. I wasn't the only one who struggled with this. If you go in the literature, Johansson in Sweden also tracked a long series of patients of men, basically 223 cases. He followed for a period of 21 years. In Sweden, they take a very conservative view to prostate cancer. And among men with low-grade disease, remember the Johansson series does not involve men with high-grade disease. This is low-grade disease. Many of these aspiration biopsies, but you can do the crosswalk to Gleason score. He had basically demonstrated the same thing, that over a 21-year period, 91% of these men he was able to follow till death, and only 16% of the population died from prostate cancer. I'm not trying to say that's a small percentage, but it basically showed this trade-off of the vast majority of men who were diagnosed with low-grade disease did not go on to die from their disease over a 20-year period. Little comment on the issue of prostate cancer and Gleason score. Now, this is something we published in JNCI called the prostate cancer and the Will Rogers phenomenon. I don't know how many of you know the term Will Rogers phenomenon. I don't know how many of you know the joke that Will Rogers was famous for, which was the Okies. When they moved to California, the IQ of both states went up. The concept is the same here. If you reclassify within categories, you can see improvements in everything. And I'll just point out what this is. For the residents, this is the original Gleason score diagram. It's probably one of the most classic figures in urology. Don Gleason was the pathologist for the VA hospital in Minnesota. I believe he's still alive. I spoke to him a couple of years ago when I was working with him on some projects. But the bottom line is the VA Cooperative Oncology Group was a large research cooperative group in the 60s. They put together several studies on trying to determine what the natural history of the disease and what the appropriate treatment was. And Don Gleason was the central pathologist. So all slides drawn in the U.S. and the VA system were sent to Don, who in turn classified it on a 9-scale, 9-pattern system. And over the years, eventually he would send his report down to the Armed Forces Institute of Pathology, and when they were starting to write up a lot of the results from the VA cooperative trials, they ran survival curves, and they realized that some of these 9 patterns actually fell into 5 distinct survival categories. So if you look at this graph carefully, you can see that if you draw a line right down the middle, the upper half is different from the lower half of the diagram. And this is basically the 9 patterns. There was a different pattern here. You can see pattern 3 is a little different on the top versus the bottom. This is how he put together what he originally had was 9 patterns into a single diagram. And this is how he tried to teach. This is pre-internet. This was how he tried to teach his system to the rest of the urologists throughout the country. Back even as late as the 1980s, the Mayo Clinic had its staging system. Johns Hopkins had its staging system for urology. We did not speak the same language. It was basically Don Gleason's contribution to put this together in a bit of a common language. But what's happened is we've had a Gleason score inflation. And for we urologists who are a little older, we remember seeing Gleason 3, 4, 5 disease on pathology reports, and I'd say since the mid to late 1990s, I haven't seen a Gleason 5 in a long time. And the question is, what happened to these cases? And this was a study we did. I actually did another study in Connecticut where we went back and harvested all the original slides from men diagnosed with prostate cancer between 1990 and 1992. This was the start of the PSA era. And I took about 1,000 of these slides to one of our pathologists who had trained under Don Gleason, who I knew really knew the system well. And I gave him the box of slides and said, go out and come back when you've read them all. It was about a year later. It took him about a year to read these 1,000 slides for me. And he basically had his Gleason scores. And fortunately, I had the original path reports, how they were originally read. So these are the exact same slides. And the gray bars are how they were originally read in 1990 to 1992. The black is how they were read in the about 2004. So the exact same slides read on the exact same Gleason scoring system. You can see what happened to those old-fashioned 2 through 4 5s. They've all become Gleason 6s, and some of the 6s have become 7s, and some of the 7s have become 8, etc. So we have had an absolutely significant Gleason score inflation. The important point to that is, when you look at my contemporary when I look at the graphs I have for 20-year outcomes, if you adjust for this Gleason score inflation, you realize that the graphs are actually worst-case scenarios. And I'll show you that here in a second. If you adjust for Gleason score and you adjust for lead time, when I show these graphs to patients, most of these outcomes are probably worst-case scenarios rather than average scenarios. So it further puts this question of, what are these Gleason score 6, which to me is the one case that we're seeing a lot of, and the one that's probably most problematic, because I suspect most men with Gleason score 6 disease face only probably about a 10% risk of disease progression over a 20-year life expectancy. So why is PSA testing still so controversial? And this is something a lot of the urology residents have difficulty grasping. So let me just walk you through a little bit. The whole reason you screen is to lower mortality. And if you look at these graphs, the biggest drops in mortality are from lung cancer and from stomach cancer. Now, why did that happen? I don't think anyone believes that screening for lung cancer and doing pulmonectomies or surgery to treat this disease, I don't think anyone feels that the chemotherapy we have for lung cancer is so good. The reason why it's dropping is because we don't smoke as much. I know they still smoke a lot in Quebec, but the rest of the provinces, they basically stopped. Stomach cancer. Again, a dramatic decline in this disease. I don't think it's, again, due to anything we do for screening, or certainly our surgical techniques haven't improved. What's happened since the 1930s is everybody's bought a refrigerator and nobody has smoked and salted foods and all the stuff that we used to eat in terms of food preservatives. So in other words, what I'm getting at is changes in our environment have had dramatic impacts on the likelihood of getting a cancer. So the question is, what's going on here in prostate? This is the decline you keep hearing about, which people are saying is directly a result of screening and treatment. And if that is to continue over the next decade, I will be convinced that screening and treatment makes a difference. The problem is we're down to rates that are not that different from the 1980s. And the question is, could there be an environmental factor causing this change? And in fact, there are a number of interesting candidates. One is the fact that half the men you see now are on statins. Statins actually have a very powerful anti-cancer effect. And it could be that we're having an environmental factor that you're putting everybody on anti-lipid drugs. This actually could be causing some of the decline in prostate cancer mortality. Another thing we talked about with the residents last night is the early use of LHRH agonists. We are using anti-androgen therapy much earlier in the course of the disease compared to what we used to do in the 1980s. Could these potentially be having the impact? And the answer is yes. They are theories, and any one of these could explain it. It also could be that we are, in fact, curing a certain number of patients that we historically would have lost, and that could be contributing to this. So the question is, a whole bunch of factors could be the result of this recent decline in prostate cancer.
Peter, where would breast be on that?
Pardon?
Where would breast be on that slide?
Well, breast, as you know, this is from CA publication. They always have a male one and a female one, and since breast cancer is relatively rare in male, that's why it's not on this graph. I think there's been a modest decline in breast cancer. I have not looked at that graph carefully, but it's there, so we can pull that up later today. Yeah.
The rise in mortality
Oops.
you see at the PSA, or do you attribute that to the fact that there's lots of guys dying of prostate cancer than we did when they were dying of prostate cancer? Do you attribute it to something else?
That's known in the business as, let me repeat the question, why the rise in prostate cancer up until the early 1990s, right when PSA testing became widespread? This is something called attribution bias. The question is, are we correctly classifying men who previously would have died of something and we didn't recognize they died of prostate cancer? The answer is yes, you could. There are a series of articles. Rocky Foyer is the lead author on that from the JNCI that discusses a lot of the potential recording artifacts that can impact incidence and mortality statistics. It's kind of fun, interesting reading. I don't know about fun, but certainly interesting reading. But no, we don't have a good explanation for the rise. But the point is, when people talk about the decline, they always start the percent decline from up here. They never talk about what the absolute values are. And the most dramatic percent decline is from this point, rather than maybe measuring from here, where the drop is not so dramatic. So whenever you hear about relative decreases, you always have to ask yourself from a statistical point of view, a relative decline can look very dramatic, when in fact the absolute change can be relatively modest. And we'll come up to that in a few slides from now when we review the Bill-Axelson data. Again, just want to point out from the UK, we have a publication pending in Lancet that's coming out on these statistics, which are further documenting that we're also seeing a decline in prostate cancer mortality in the UK. This is an area, it's not falling anywhere near as fast as the US, but the prostate cancer rates are falling in the UK, and as you know, they do not do aggressive screening and treatment, so we know there is a partly environmental impact, but the rates of decline are much faster in the US over the last few years, so I think both factors are working together. This is just a little schematic to help, again, understand a little bit of what's going on here. As you can tell, prostate cancer is a chronic disease which progresses over time. So we have a time axis on the y-axis here. This is time from being diagnosed with the disease to dying from prostate cancer. versus the x-axis, another time axis. This is the progression of other diseases that kill you, heart disease or Alzheimer's, or a whole bunch of things. And this is a race between the rapidly progressing tumors that wind up resulting in death from prostate cancer versus the slowly progressing tumors which do not kill you. You can live with them. And you can see that in some instances, these are the men. In fact, let me go to the next slide. When I was a resident, the paradigm we had was the vast majority of men were what I call the green men. The green men are those men who were referred to urologists with bone pain, decreased appetite, weight loss, men who clearly had advanced disease, and the vast majority of these people went on to die from prostate cancer, and we were aware of them. We didn't see the orange men. The orange men were those older men seen by the internist who might be aware of a firm nodule on prostate, but the patient looked well and there was no complaints and there was no reason to send them to the urologist, and they happily lived on and then eventually died of their heart disease. And the world was filled with orange men and green men, and life was good. Along comes PSA, and we dramatically increase the number of men diagnosed with this disease. I just showed you that graph of the SEER statistics. We did. We've doubled the number of men diagnosed with disease. So we've doubled the number of green men and orange men that are out there. Again, your perspective on how many green men are there or how many orange men are there are depending a little bit on what you see in life. It's kind of like the elephant. Where you palpate dictates what you think an elephant is. But let's go one step further. Green men are characterized by rapidly rising PSAs, and orange men are characterized by slowly rising PSAs, because we know that PSA doubling time is a powerful predictor of outcome of this disease. Orange men have a relatively long lead time between when they could potentially be detectable by PSA and when they became clinically apparent. Green men, the one who are likely to die of their disease, have a relatively short window between when they might have disease detectable by PSA and when they would be clinically detectable. And the problem is, when you introduce a program of annual PSA testing, which is basically what we do in the States, and I suspect what you do here in Vancouver, over time, you have many more chances to diagnose an orange man than you do a green man. This is called length bias. And epidemiologists have taught us over the years that if you repeatedly screen for disease, over time you start selecting for the less aggressive cancer. And this is something that any of us who've been in practice for 10 or 15 years are really beginning to feel personally, because the number of men that I used to see with Gleason 6 disease, 1 or 2 cores positive, was relatively rare a decade ago. Now I'm seeing it very frequently. And anyone who's been in practice a while probably has senses the difference in the type of biopsies we're seeing. I mean, 10 years ago, most men would have 4 or 5 or 6 cores, and most of them would be positive. Now we get 10 or 12 cores, and 1 or 2 or maybe 3 cores are positive. I don't see as many Gleason 8, 9, 10s as I used to. So I can sense that I personally am seeing many more orange men than green men, and this is why. You would expect that after 10 years of aggressively testing for this disease. I think the publication that drove all this home to all of us is Ian Thompson's publication from the Finasteride screening trial. This, for those of you who read the New England Journal back in 2004, this was the Finasteride trial that people either got placebo or Finasteride, and the purpose was to try to prevent prostate cancer. When this publication came out, one of the first things I ran to look at in this paper was how was this study powered? And if you look at the line carefully, when they did this study and calculated the sample size, they predicted that in the placebo arm, they expected a 6% rate of prostate cancer. And they powered the trial such that if it was successful, Finasteride would lower the rate of prostate cancer by 50%, and they expected in the Finasteride arm, the rate of prostate cancer would be 3%. And they followed these men for 7 years. All of these men had PSAs under 4. They were men in their about mid-50s all the way up to 70s. So these were men that most people agreed did not have prostate cancer, were clearly candidates for cancer prevention. And what they discovered was, when they biopsied everybody at the end of the study, fully 20% of all the candidates had evidence of prostate cancer. I mean, this is huge. This is saying you brought a bunch of guys together and expected a 6% rate of prostate cancer, and after 7 years you biopsy everyone, you're seeing 24%. That means you're seeing 4 times as much cancer as you thought you had from previous epidemiologic studies. And when you ask yourself, what were the majority of the cancers they found? It was our old friend Gleason 6. This is the cancer that dominated the number of new cancers found in the Finasteride screening study. So we now know for sure there is a huge reservoir of Gleason 6 disease out there of men who may or may not ever die of this disease. And that's the evidence base that I think strongly supports this view. The problem is there are a couple of these guys out here, 7, 8s, and 9s, who had PSAs less than 4, and I can't tell you that all of those Gleason 6 men are not going to go and have progressed with the disease. So we're still waiting for Martin Gleave to come up with a special test, that genetic marker, that's going to tell us which Gleason score 6 are the bad guys from the good guys. But seriously, that is the holy grail of urology in 2008. If you do those calculations, though, and you ask yourself, all right, let's look at this Finasteride screening trial. Let's assume we should have had a 6% death rate. When you do the math of the number detected and the ones how many you expected, it comes out that the orange men are about 3/4 and the green men are about 1/4 of this pool of cases. So if I had to put a number on how the number of orange men and green men play out, it's about 1 out of every 4 men will have clinically significant disease, 3 out of every 4 men will have insignificant disease. This is a huge epidemiologic burden. Let me take you back to and close up here, a manuscript that I published. I don't know if Larry, you remember this one. This is my first major publication in JAMA in 1993. I was vilified for this manuscript. I was actually considered, I almost got thrown out of the AUA for this one. For those of you who may have been there, this was the Monday morning plenary session. This masthead was flashed to the entire AUA community. And Tom Stamey and Scardino and Catalona and a whole bunch of people were on the stage and told the world what a bunch of crap this was and they should ignore it. And I'm bringing it back to you because what we did here was struggling on this decision analysis of what's the impact of treatment. And we created a Markov model. And one of the key slides from this was this. We had 10 years. We said a 60-year-old man, 10 years post-treatment, if he had watchful waiting versus a radical prostatectomy versus radiation, you could expect that in the watchful waiting arm, you'd have about a 10-14% rate of death from disease. It would probably be half of that, about 7% if you had a radical prostatectomy. During those same years, you'd expect about a 30% rate of dying from other causes, and about the same for radical prostatectomy. And about 60-65% of the men would still be alive with their disease. This was a computer model, had nothing to do with data, except it had to do with the data we had at the time. We tried to impute that. And I point out that if you look at the Bill-Axelson data, which was just published in the New England Journal of Medicine not too long ago, and look at the cumulative incidence of prostate cancer at 10 years, you'd be surprised to see that in watchful waiting, about 14% of the men died from prostate cancer, and about half that, 7%, died from prostate cancer. This is exactly what our model predicted in 1993, and 10 years later, we're having data that shows that's exactly what you'd expect. In fact, when you go the next step and say, what happens to the men? Are they likely to die of other causes? That's exactly what we're seeing. Roughly similar rates of death from other disease. That's approaching 30%. I just talked to Jan Edelson about a month or two ago when I was in London for the Protectile meeting. Those two curves that were statistically significant at 10 years have merged back again, and at 12 years they're no longer statistically different. So again, it's fascinating how this group is as they continue to follow this up. If we put in modern day lead time as a result of PSA testing, remember the Swedish trial is among men who were found in the pre-PSA era. So if you look at this data in contemporary terms, you should add a lead time of about 5 years. So what this is telling us, these are 15-year outcomes. When I look at the Bill-Axelson data, I'm seeing essentially 15-year outcomes. And a recent SEER analysis from Fox Chase Cancer Center pointed out if you look at all the men 65 to 80, what happened if they were observed versus treated. The outcomes are pretty similar. So what have we learned in my mind over 20 years of PSA testing? We absolutely agree that PSA testing can identify prostate cancer among a large number of men, probably as many as 20% of men over age 50. A majority of these tumors are probably Gleason 6, and at this point, I suspect a significant number of men with Gleason 6 disease probably do not have disease that's going on to kill them. We also know that many men with Gleason 7 disease and most men with Gleason 8 to 10 tumors clearly have significant disease and will likely die of their disease if left untreated. We know that surgery has a probability of decreasing the death rate from prostate cancer about 50%, but the significant impact from that treatment probably is not felt for a period of 10 to 15 years after surgery. Hence the 10-year rule. If someone doesn't have a 10-year life expectancy, you probably aren't doing them much of a favor either by operating on them or radiating them. Fortunately, we don't have similar data from radiation therapy. The PROTECT trial in the UK is hopefully going to give us some of those answers, but we're still 10 years away. We know that screening has dramatically increased the number of new cases of prostate cancer by a factor of 2. And as I said, intervention can alter the outcome in a small percent of these men, about 10% over a 15-year period. And so then when you do the math and ask yourself, how many men do you have to treat to save one or to extend the life of one patient? Conservative estimates put it at least 10 or 20. Some people would say as many as 50 to 80. So these are tougher things that you have to balance. And that's where I come to the last point is the one life extended must be balanced by all those other lives you intervened on and you potentially altered their quality of life. And we had some of this conversation last night at dinner. In my mind, the main onus on any urologist who's taking care of this disease is, since you're not always certain you're going to help the patient, for God's sakes, don't make him any worse. So work hard on your techniques, work hard on what you advocate to the patient, so when they leave your hands, their quality of life is really not any worse and certainly potentially improved if you in fact altered the outcome of this disease. And last one, at this point, the data are clearly insufficient to support a public policy of screening for prostate cancer from a cost-benefit analysis. This is why most of the countries in Europe, and virtually every European country has come to this conclusion. They don't necessarily support PSA testing and promote it as public policy in Europe. They're not completely daft. And in fact, a lot of the Europeans think we in North America are a bit daft in our approach to this disease.